Thank you. Thank you for the introduction. So what I hope to do is give you a little bit of an overview of what we are up to in cancer genetics currently, and also highlight some of the challenges that remain within the field. And I would like to spend the last probably 10 minutes actually talking about multi-gene cancer susceptibility testing. So it was almost 100 years ago now that Dr. James Ewing, who was actually a professor of pathology at Cornell and at Memorial Hospital, very astutely said, nothing about cancer is more generally accepted than its hereditary nature, and nothing is less satisfactorily proved. And I think we've come a long way in our understanding of cancer susceptibility. We know from very nice publications from the Scandinavian registry studies of monozygotic and dizygotic twins that a lot of common cancers are mediated by genetic susceptibility, and this is certainly true for the three common GI cancers, including stomach, colon, and pancreas. And what's also become relevant is that genetic risk assessment, as Dr. Gottwald mentioned, is becoming a very important part of our management of our GI patients. So it may have implications in pre-surgical decision-making, obviously in Lynch syndrome, but even in things like hereditary diffuse gastric syndrome. Dr. Siegel already mentioned that in terms of treatment with immunotherapy, certain patients may qualify with Lynch syndrome. Also, we know that mismatch repair deficient colon cancers, especially in the stage 2 setting, you may alter your decision with respect to need for chemotherapy and what type of chemotherapy you may use. And then last but not least, for those patients that survive their cancer, there are implications for cancer surveillance and prevention. And then obviously it has implications for family testing and prevention of these cancers in other members. So I'm going to start with the most common cause of hereditary colon cancer, which is obviously Lynch syndrome, and that accounts for 3% of all colorectal cancers. But then I also briefly mentioned some of the new cancer susceptibility genes. I won't spend much time on management of FAP, but rather concentrate on the new genes so that you're at least aware of what's new and what's out there. So Lynch syndrome is obviously autosomal dominant, early onset colon cancer, and usually right-sided. And these are the 4 genes that were traditionally implicated with Lynch. But what has become very apparent is that actually PMS2 and MSH6, which we thought were very rare, are actually probably much, much more common than MLH1 and MSH2. So why the shift? Well, because the families that we initially ascertained and tested for Lynch were the really very strong family cancer history of colon cancer, uterine cancer. And we generally found MLH1 and MSH2 mutations, but PMS2 and MSH6 have a much lower risk of colorectal or endometrial cancer. So those patients may not have made it into a genetics clinic for testing. Now that we have broadened our clinical criteria for genetic testing for Lynch, we are finding more and more of these mutations. So what is the cancer risk in Lynch? Well, colorectal cancer, traditionally 50 to 80% is probably a little bit lower than that, especially in MSH6 and PMS2 carriers. Endometrial cancer risk is very high, especially in MSH6 carriers. Increased risk of urinary tract cancers, increased risk of small bowel. There's the Muir-Torre variant, where you see sebaceous adenomas, sebaceous adenocarcinomas, and then also an increased risk of pancreas cancer. Others that we sometimes see, but I think are emerging, are adrenocortical tumors, and possibly a small increased risk of breast cancer and maybe prostate. And the prostate is usually MSH6, so it's something that we don't generally test for, but we may, that's sort of an evolving field. So how do we test for Lynch syndrome? Well, in GI malignancies and colorectal cancers, we test for mismatch repair deficiency or microsatellite instability, which is basically the hallmark of a deficient mismatch repair system. The tricky part is that about 15% of all colorectal cancers exhibit mismatch repair deficiency, and only a small percentage, again, about 1/3 of those 15%, represent Lynch, while the vast majority of patients actually have an acquired somatic event within their tumor. That can be like a BRAF V600E mutation or MLH1 promoter hypermethylation that knocks out your MLH1 gene and results in an MSI high mutation signature. So who should screen for Lynch? So this used to be very complicated. We had the Amsterdam criteria, then the revised Bethesda guidelines, but they both have limited sensitivity and limited efficiency in some ways with the Bethesda guidelines. And in fact, up to a third of Lynch patients would be missed if you just used revised Bethesda guidelines. So this has become very straightforward, and the recent NCCN guidelines now say universal screening of all individuals with newly diagnosed colon cancer should be screened for markers of Lynch syndrome via tumor tissue testing. Some institutions are still doing age 70 and under, which is also reasonable. So how should we screen for it? Well, tumor testing is really the way to go. So you can do either immunohistochemical staining for the mismatch repair proteins. An absence of a protein is suggestive of mismatch repair deficiency, or you can use the traditional microsatellite instability analysis, which is a PCR-based method that looks at a panel of microsatellites, and having two or more markers that are unstable is consistent with an MSI high phenotype. The concordance between the two is pretty good. My preference is IHC because it helps direct our genetic testing. So that's what we do as a reflex test for all patients who undergo colorectal surgery at our institution. So subsequent to IHC testing, if the IHC is normal and you're not concerned about the family history, it basically rules out Lynch. If there's loss of MLH1 and PMS2, then usually you go on to reflex BRAF V600E mutation testing, which essentially rules out Lynch syndrome. Or you can do promoter hypermethylation testing or MLH1 testing. We do both at our institution. So that if you have these either hypermethylation, promoter hypermethylation or BRAF, then basically you're done. There are a few exceptions to this. If you don't have BRAF or hypermethylation, then you really need to refer them to us for genetic testing, for germline testing. Or if you have absence of just MSH6, just PMS2, or MSH2, MSH6 combination, then you really do need to refer them for further germline testing. If in doubt, just refer them. It's interesting because while you can do IHC and microsatellite instability testing, what's sort of beginning to emerge is that especially in the metastatic patients where you're doing a larger next-gen sequencing tumor panel like Foundation Medicine or for us at Memorial, the MSK-IMPACT tumor profiling, what has become very apparent is that patients with a very high mutational load or mutational burden, so those that have a lot of mutations, are often mismatch repair deficient. And in fact, our NGS panel is very good at picking up microsatellite instability or mismatch repair deficiency just based on the mutational burden. And in some ways, this is interesting because then you also get the result of the BRAF immediately. And if you're suspicious of a Lynch-like syndrome where you don't have a germline mutation, you can look for double somatic hits in the mismatch repair genes as a cause of the mismatch repair deficiency. So what do we do with patients who are identified as having a germline mutation? So we do colonoscopy at Memorial. We do every annual colonoscopies, but the true recommendations are 1 to 2 years. Chemoprevention will be the next slide, but I think we talked about that earlier today. Risk-reducing colectomy, potentially. It's an option for in gastric cancer screening. There is no good screening. That's why it's in parentheses, but we do recommend usually EGDs every 3 years or so. Endometrial ovarian. So now the FDA has actually put out an announcement against ovarian cancer screening, even in high-risk populations. So we no longer recommend that, and that's true for our BRCA patients as well. But we do recommend risk-reducing hysterectomy with BSO in our Lynch patients upon completion of childbearing. Urinary tract screening, no data that it works, but we do sometimes do it. It's usually urinalysis looking for red blood cells in the urine. So in terms of the CAPS-2 study, again, this was 600 milligrams versus placebo of aspirin, and what you see is this reduction in colon cancer risk and other cancer risks with the addition of aspirin. And again, we generally don't recommend such high doses, but it's relevant that this is now considered a positive study. Other implications in Lynch of finding mismatch repair, I should say, in colon cancer, is not just the diagnosis of Lynch, but also the prognostic and predictive marker that mismatch repair deficiency tells you, and also this marker of response to immunotherapy that Dr. Siegel already went over. So moving on from Lynch to the polyposis syndrome, so this is FAP, traditionally hundreds to thousands of polyps, mutation in the APC gene. Oftentimes this is de novo, and it's oftentimes presents in childhood or in the teenage years, and those are the other cancers listed that are associated. What perhaps is a little bit more common and perhaps more interesting is that you can also have an attenuated version of this syndrome where the mutations are actually on the 3' and 5' end of the APC gene, and it results in less than 100 polyps, so oftentimes you can manage it with colonoscopy. Generally later onset colon cancer if they're going to get it. Associated with it, very clinically similar, is MYH-associated colon cancer. And this is an autosomal recessive syndrome. Having one MYH mutation does not confer a high risk of cancer. Maybe a touch, maybe about 1.4, 1.5 increased risk of colon cancer, but it's really having 2 genetic mutations in MYH, so biallelic mutations, that confers the high risk of polyps and high risk of colon cancer. So that's a relatively new gene. And then also the newcomers are the mutations in the polymerase proofreading domains, and these are really interesting. So this is a family with multiple polyps and very early onset colon cancer, and this is due to germline mutations in the POL-E, and also in POL-D1 you can get germline mutations, and in the POL-D1s we also think that it's actually associated with probably brain and maybe endometrial cancers as well. The full spectrum of cancers associated with this is not really known yet. It is autosomal dominant. And I had down there that it's microsatellite stable, but we just had a germline POL-E carrier who had an MSI high tumor because the ultra-mutated phenotype of the POL-E tumor actually knocked out her MSH6 somatic gene and ended up with a mismatch repair deficient tumor. So what I'm trying to point out here is that in addition to Lynch, there are many, many more genes that are implicated in colon cancer susceptibility, some of which are listed here, and including low penetrance genes that are associated with maybe a 2-fold increased risk of colon cancer, but the clinical utility for testing for those is not really proven yet. So moving on to cancer syndromes associated with gastric cancer susceptibility, the only one I'm going to touch on is hereditary diffuse gastric cancer associated with lobular breast cancer and mutations in the CDH1 gene. The criteria for who to test for this, it's very early onset diffuse gastric cancer, generally less than age 40, or those with a strong family history of diffuse gastric cancer or lobular breast cancer. And it's thought that Napoleon actually had this syndrome in his family. The gastric cancer risk is up to 70% in men, about the same in women, and a very high risk of lobular breast cancer. As you know, lobular breast cancer is not well picked up on mammo, so they do need MRI screening in addition to mammogram. And the treatment for patients who are diagnosed with this mutation is prophylactic gastrectomy. And the reason is this. So this is 8 gastrectomy samples from 8 patients with CDH1 mutations who underwent a gastrectomy, but prior to gastrectomy, they all had upper endoscopies that were negative despite multiple biopsies. And what you see here is on close pathological evaluation of the gastrectomy samples. All of those little yellow stars represent foci of signet ring cell carcinoma. So basically, endoscopy does not work in this disease, and if there's a CDH1 mutation, then gastrectomy needs to be done. Pancreas cancer, very strong familial component. So we know the estimated lifetime risk is 1.3% in the general population, but just having one first-degree relative with pancreas cancer, the lifetime risk goes up to 6% and dramatically increases the more family members you have. These are the genes that are associated with pancreas cancer. I think the ones that I need to highlight for now are BRCA2 and BRCA1. Recently, the NCCN guidelines have changed, and we worked very hard to publish our data on our Ashkenazi Jewish families to prove that, in fact, all patients with pancreas cancer of Ashkenazi Jewish descent should get tested. And now that's part of the NCCN guidelines. Medicare is still not necessarily covering it, though, but hopefully that will change soon. The other one that I should point out is PELB2. PELB2 is at the very bottom, associated not just with pancreas cancer, but also breast cancer. On multi-gene panels, we are picking up a lot more of these, so probably more to come on the penetrance of that. And the risk of breast cancer is about 50% lifetime risk, so very close to BRCA2, a little bit lower than BRCA1 in terms of breast cancer risk. So our standard approach in genetics to date has been basically single gene testing. You look at the tumor, you look at the cancer phenotype and the family history, and you test generally 1 or 2 genes at a time. And there's now, with next-gen sequencing, there's multi-gene panel testing that's available, where you basically do simultaneous analysis of a set of genes. And some of these genes may be associated with the phenotype that you're looking at, and some may not be. And some may be high penetrance genes, so associated with a high risk of cancer, and some may be these moderate or low penetrance cancer genes. And so this is just an example of 4 different companies or institutions that have multi-gene testing panels for colorectal cancer. You'll recognize a lot of the genes, but some of them are probably like RPS20 or GALAN12 are less associated with colon cancer, and we don't really know what the risk of colon cancer is within with mutations associated within those genes, even though they are components of these panels. So what's the advantage of doing such testing? But it's more efficient than coming back 5 times for single gene testing. Potentially cost effective. There's an article in JCO suggesting that it is. And maybe you'll find more. So this is sort of making a case for multi-gene testing. So here was a gentleman that was referred to me by one of my Medan colleagues, 46, I believe, year-old gentleman with colon cancer, and also had a ureter cancer a few years back. So it looked like it could be Lynch syndrome, but the IHC was normal. So it was referred to me. He also had about 16 polyps, a little bit more polyps than I tend to see in Lynch. And so given the IHC was normal, I ended up doing a panel on him. And in fact, what we found was a POL hotspot germline mutation. So this is, POL E is probably not the first gene that I would have jumped to. So multi-gene testing in this case was obviously an efficient way of finding this particular mutation that has implications for him for screening and for his family members. Matt Jorgelen from Dana-Farber put together this nice study of a clinic-based colon cancer ascertainment. This was just published in JCO a month ago or so. And they did 25 gene panel, but it included things like BRCA, P53, and about 10% of 1,000 colon cancer patients that were consecutive patients coming to Dana-Farber. So the mean age was a little bit younger just because it was a tertiary cancer center. But what they picked up is about 10% had a pathogenic mutation. And you can see that it wasn't just Lynch. It was also things like BRCA1, BRCA2, P53, CDKN2A, so things that are not necessarily associated with colon cancer. Now, were these just incidental findings, or did they actually cause their colon cancer? We don't know. In our population, we are doing this MSK-IMPACT testing for tumor profiling, but at the same time, we do it with a matched normal blood control, and we have a separate protocol to look for germline mutations in 76 cancer predisposition genes, which are on that panel of 410, I think now 468 genes for the tumor profiling. And what we found in our first 1,000 cases, and this is currently under review, is that about 17% had an actionable mutation, but some of those actionable mutations were lower penetrance genetic mutations. And we would not have identified about half of these with just using NCCN guidelines, for example, for clinical diagnosis or clinical testing. Unusual findings were in biliary, prostate, colorectal, renal, and pancreas cancer. And these actionable findings led to discussion or initiation of change to targeted therapy in nearly 20% of patients. Interestingly, 40% of the Lynch cases that were identified were incrementally detected. We would not have done IHC analysis for it, so it wasn't our colon cancer and our endometrial cancer cases. So this all sounds great, but then what are the challenges of panel testing? Well, the clinical utility of these incremental findings has not really been demonstrated, and we also have off phenotypes findings, as well as variants of unknown significance. So whenever we think about doing a genomic or genetic test, we have to, or any test for that matter, we have to think about 3 different aspects of that test. One is analytical validity. So that's the ability to accurately and reproducibly measure the genotype. Basically, all of the labs that offer such testing have this. So once, if they find a BRCA mutation, then they'll find it the next time too. That's basically analytical validity. Clinical validity is ability to accurately and reliably predict disease or outcome. So if you have a BRCA mutation, you know it's associated with an increased risk of breast cancer. If you have a CHEK2 mutation, well, what does that mean? Does it trump family history or does it not? We're not sure. And then last, clinical utility, that the test result is used to improve clinical measures. And what I want to argue is that for a lot of these genetic panel tests or genes on panel tests, the clinical utility has not been proven. So what you see here is in the left upper corner is high penetrance genes. So taking a familial colon family, this is Lynch syndrome, for example, right? So it has clinical utility because you tested for it, and now you're going to screen that patient or their family members differently. You can find high penetrance mutations, but that's off phenotype. So that would be a BRCA mutation in a colon cancer family. Well, are the breast and ovarian cancer risks in those families the same as in a breast ovarian family? We don't know. Moving on to the low or moderate penetrance. So limited is maybe a single MYH mutation or a CHEK2 mutation in a familial colon family. We know it's associated with maybe a twofold increased risk of cancer. Does that really change your screening guidelines when you already have a family history of colon cancer? Probably not. And then you have your findings of low or moderate penetrance genes that are not associated with the cancer phenotype. So this is like an MBN mutation or RAD51 mutation or BRIP1 mutation in patients with colon cancer family history. We have no idea what to do with these. The other issue with panel testing is genetic variants of unknown significance. So you know that these genetic test results come in positives, negatives, and in between. And with the more genes you test, the higher your risk of obtaining a VUS result. Generally, management is based on family history, not on the VUS. We do not make prophylactic surgery decisions based on the presence of a variant of unknown significance. In fact, there is actually, the NCI put together this whole clinical genome resource, and for each specific cancer, there is a gene curation team, and I'm on the colon cancer gene curation team, and we spent hours analyzing each gene and then each variant and trying to decide whether there's enough experimental evidence to say that this gene is truly associated with colon cancer and whether that particular variant is associated with a risk. So I think as we test more and more, I think we have to understand that there's so much that we don't know, and we don't know how to, where to put these results and how to incorporate them into patients' care appropriately. So in conclusion, Lynch syndrome, I think the new guidelines are all colorectal cancer patients should have tumor screening for markers of Lynch. There are a number of new genes that I think I highlighted. There are probably a number of new genes that are yet to be discovered. And the multi-gene panel testing, it's okay to do in certain cases, but not everyone needs an 80-gene panel for a run-of-the-mill colon cancer. Thank you.